So this is a 50-year-old gentleman who presented to us with a gradual decrease in vision in his right eye over the past 2 years. His ocular examination was essentially normal except for what appeared to be a mature cataract in his right eye. But upon dilatation, we were taken in for a surprise as what we saw was something else. And he had especially, this was a surprise for us because he had given us a history of cataract surgery being done 10 years back bilaterally. So my first question to the panel, Dr. Meenu can take this. Based on the presentation that we showed so far, what do you think your diagnosis in this case is, and how would you plan, what would be your approach to managing such a case?
Giving a history of cataract surgery. So basically on slit lamp examination, we can actually see that the IOL is opacified, and there is also anterior capsular calcification contraction at the edges. So for this patient, we would definitely like to go for an IOL exchange, and we need to counsel the patient because mostly it looks like a foldable IOL. Maybe the patient had a phaco with an IOL, can't be sure looking at this picture. But we need to counsel the patient that the IOL needs to be exchanged and then plan the procedure depending on the patient fitness and everything.
Thank you, Dr. Meenu. Can we play the video, please? So that was absolutely correct. The patient had presented with an opacified IOL, and our surgeon decided to proceed with performing a small incision cataract surgery in order to explant this lens. Viscodissection was done using a dispersive viscoelastic in order to separate the intraocular lens from its capsular attachments. Over time, the haptics of the lens can become fibrosed, and the anterior and posterior capsule can fuse, making it difficult to explant the lens without damaging the surrounding structures. So as you can see, the IOL was quite adherent to the capsular bag in this condition. So Dr. Neeta, if you can take this next question, what would you do next in such a situation where the IOL is so firmly adherent to the capsular bag?
I would definitely make an attempt to get it released almost all around, and I see that it is being done on the right side, similarly on the left side, and in case it is loose at any of the two ends, I would prefer to get that end out before I handle the other one, and then see that I have enough viscoelastic below the IOL with a maybe thinner cannula than what was used to put the viscoelastic, so that it goes into the space and prevents any adhesion between the remaining capsule or the posterior capsule and the lens, because a lot of these very often have adhesions which are there, which we could see on the right when it was being separated out.
Correct. Just for paucity of time, this video has been shortened, but the surgeon made multiple attempts to separate the IOL from the bag. So just to ensure that there was no damage to the zonules, what was attempted next was, just in view of safety of the procedure, the surgeon thought that it would be safer to amputate that haptic and remove the optic first. So that is what is being done. It was done using IOL cutting scissors. So the first end of that haptic was cut, followed by the second end, and this was done using a Sinskey hook to displace the IOL from the bag, out from the bag, making it easier to cut that haptic. So once the haptic was cut, it was quite easy to exteriorize this opacified lens along with the other haptic, and that's what's come out. You can see this opacified lens over here. But there was something else lurking behind this lens, and our surgeon noticed a sudden change in reflection and paused to look and decide something more ominous lurking behind this lens. So again, my third question, Dr. Ramamurthy, if you can take this. What do you think has happened, and when do you think what has happened has happened?
I think you have a PCR.
Yeah.
And maybe it was, but of course it's the soft haptics of the lens, but maybe it was during the explantation procedure or during the maneuvering when, when the lens was being maneuvered, that a small nick could have been created. When the intraocular lenses was forcibly being removed, it got extended.
Correct.
But I think you're in a reasonably good situation. You have such a nice round rexus.
Correct.
And all you have to do is to do a good anterior vitrectomy assisted by transluminal. And since it was a monofocal lens, you can go ahead and implant a monofocal implant and create an optic capture in this.
Yeah, so you've given out all the answers to my next questions. So if we can play the video. Our surgeon performed a thorough anterior vitrectomy, and as Dr. Ramamurthy rightly said, diluted triamcinolone was used to ensure that there was no residual vitreous left in the anterior chamber. Microforceps were used from the other side port in order to extradite this other haptic. It was brought gently into the anterior chamber and then carefully removed from the eye. So again, Dr. Meeno, if you can take this question, where would you place your lens and what are the options for secondary IOL placement in this situation?
So now, since in this case the anterior capsule is intact and we can see the entire edge, we can go, as sir has already mentioned, we can go for a 3-piece IOL and we can have an optic capture to secure it in the center. Or in the bag, I'm not sure how much of the, we don't know how much of the posterior capsule is intact. So we would like to go ahead with a 3-piece IOL in the sulcus.
Correct. So our surgeon decided instead of a 3-piece to place a PMMA lens in the sulcus. And you can see the lens going into that sulcus. It was gently placed there and then using a Sinskey hook dialed into position. We could have done an optic capture, but in retrospect that was not done. You can see that the optic was well centered in the visual axis in these images at the first post-operative week. And when the patient came back to us at 1 month, he was very excited with his vision and he was quite satisfied with the visual outcome in the right eye. So my final question to all the panelists, what are your learnings from this case, from your vast experience in performing this procedure?
So retrospectively, first this was handled very well, but retrospectively, I think it would have been maybe better to hold it with the microforceps rather than the Sinskey hook. The chances of damage with the scissor would have been maybe less. And the fact that the remaining haptic came off so easily after the vitrectomy indicates that it was stuck. And that is why it was not coming out earlier. So maybe if the cut had been made a bit more on the optic side, and maybe if we had taken out the other haptic first, the chances of us damaging the PC would have been maybe less. But again, this is purely on hindsight. And last, with such a big incision, I would maybe take a suture to reduce the astigmatism.
Yeah, okay. I think we've run out of, no, Dr. Ramamurthy, please.
I think first thing I would like to make sure that the patient is really bothered by the opacification of the lens. You know, quite often you see these glistenings and subsurface nanoglistenings. It bothers the doctor more than the patient. And quite often it's a small drop in the contrast sensitivity. The visual acuity is reasonably good. These lenses need not even be taken out. But then the case you showed, when it's so significant, it has to come out. I would not, as was suggested, would not be in favor of making such a large incision. The special lens cutting forceps and scissors that is available. Go through the side port, stabilize the lens, go through the central 2.83 millimeter. Just 1/4 of the nick on the lens is enough, and you can rotate the lens out. That's a more controlled way of doing it and less prone for complications. But as was shown, if the haptic is stuck, especially with single piece haptic, cutting the haptics and leaving them behind and just bring the optic out is not a bad idea. I think overall well managed case.
Thank you, thank you. Thank you again.